Just three ordinary guys trying to understand the crazy world around them. We don't have all the answers, but we've got all the questions. You're listening to Just Add Bourbon with Jimmy, JD, and Brad.
Welcome, everybody, to the Just Add Bourbon podcast. I'm Jimmy Don Kerr.
I'm Brad Broaddus.
And I'm JD Dammer.
And tonight, guys, we've got another special episode. We're doing an interview with a gentleman who came to us from Manchester, Kentucky. His name is W Madden. He is a DO, family physician, specializing in osteopathic manipulation. And the point of this episode is just something we actually heard Jared on a KET show. And the subject was medical marijuana. And so we asked Jared to come on with us and discuss that topic. So, Jared, thank you for coming. We appreciate you heading all the way up here to Inez, Kentucky.
Great to be here.
So just really to kind of start us off, can you kind of tell us what osteopathic manipulation is? How does that compare to like a normal family physician?
Traditional MDs that we're used to. Actually, if you want to back up, we have in the United States, we have two different branches of medicine that have basically unlimited license to prescribe medicine, perform surgery, deliver babies, to do the works. And those are both MDs and DOs. We traditionally study almost entirely the same curriculum, except in the osteopathic field, we also study osteopathic manipulative treatment, osteopathic practices and principles, which, if you had to compare between the MD world and the DO world, the osteopathic world may be a little bit more focused on trying to find or elicit a cause as opposed to cover up symptoms. That's sort of the easy way to look at it.
So is it more kind of like a holistic type approach?
A more holistic approach is one way to look at it, although I think the MD community has come a long way to looking at the body a little bit more holistically, but the foundations of our philosophy are a bit more holistic, I do believe.
Okay. I guess my next question would be, I heard you or saw you on KET, yeah. So you're stepping out on some pretty large platforms, and now you're here with us, and you're advocating for the use of medical marijuana. Like, what led you down that path?
It's actually a little interesting story as to how I got involved with the current medical marijuana legalization movement in Kentucky, but it proves what a small world and community we live in. A college friend of mine was working with Mr. Montalvo with the Medical Marijuana Initiative, the folks that are filing the bill and working with the folks in Frankfurt. And he and I were roommates in college, and we had discussions as far back as the 1990s about potentially legalizing it. My college friend, Patrick McClure, is an attorney who's worked with Normal, Gatewood Galbraith folks ever since we were in college about legalizing marijuana. And he put me in touch with Mr. Montalvo, and that's how I got directly involved with the medical movement. But when you get involved in Frankfurt, you realize I went to Center for undergrad, and a tremendous number of my former friends at Center are also working in Frankfurt these days. So once I got up there were a lot of familiar faces, and it's kept us interested. And we're filing the bill early this year, getting ready to start back up with a new legislative season.
Something that comes up in almost every one of these debates is the lack of research in marijuana. And, at the same time, you've got all of these other medications that are coming out on the market. They make it through the trials, they make it through the research, and they've got side effects that, in many cases, are worse than the actual condition that they're set to treat. So, if they make it through the FDA process, and you've got marijuana that's been around for hundreds, if not thousands of years. And to the best of my knowledge, there's never been a reported case of a death by an overdose. And the two most common symptoms can be alleviated with Visine and a box of Twinkies.
Yeah.
What do you think is throttling that research toward marijuana?
It's easy to sort of cast the bad guys, the pharmaceutical industry, but I think ultimately, if you do follow the money, that ultimately tells you where some of that issue at least stems from, be it not 100%, but the amount of money that's involved in bringing a drug, through the trial stages to production and into the prescribing realm, it requires a tremendous amount of money. And I think that the nature of marijuana, the potential for self-grow, you remove that bad guy aspect from the equation, and so there's no motivation from an industry to perhaps push something through a trial process and to do the studies that are involved. And to back up one step further, I think we often point out that there are not a lot of studies, but if you expand your search into the international market to some of the places where medical marijuana has been in use for a lot longer, there actually are a wealth of studies that prove its safety and efficacy for a wide variety of conditions that other drugs, as you point out, can be extremely toxic with respect to side effect profiles.
My main question would be, we've got this pushback from medical marijuana, right?
Mm-hmm.
And we have all these states that are generating all this revenue with not only medical marijuana, but recreational marijuana.
Yep.
And do you see us in the state of Kentucky taking the path forward if we ever do get medical marijuana?
I know that for some folks that's an element of concern, and currently in the state of Kentucky with our medical marijuana initiative, we want to remove that element of complexity from the situation and sort of separate the recreational versus the medical point of view. And I can understand that. From a personal point of view, I've traveled in Colorado, I've traveled in Nevada since it's been legal in Colorado and back to 2013. And I think if you look at the numbers from the money they're drawing from taxes, the revenue, it's tremendous. So why we continue to cut our nose off to spite our own face is beyond me. When we have issues with funding pensions and things of that nature in our state, to sort of look a gift horse in the mouth. I realized one of the gentlemen running for the Agriculture Commission had numbers that suggested a potential income per household of $40,000 for 1 acre of medical marijuana. So you talk about money that we could put in our own pockets. I don't necessarily understand why, but ultimately I think it goes back to the folks that are in power.
So, looking just from the medical marijuana side of things, like, what is a case where you would look to prescribe medical marijuana?
Actually, there are a host of different conditions that come up. I think some of the more interesting ones, we talk about nausea with chemotherapy, some of the ones that we're familiar with, glaucoma. It's been an effective treatment for that condition, and we've been aware of that for years, to the extent that comedians joke about it as being a treatment. The ones, as I got more involved in the medical end of things, and understand my practice is geared primarily at pain management. I'm a family practice doctor, but most of my practice, 95%, is geared at the management of musculoskeletal pain conditions, be they acute or chronic. And I'm trying to find non-narcotic, non-pharmacological ways to intervene, and that's the nature of osteopathic manipulative treatment in my practice. But I do come across a whole host of conditions which we could refer to loosely as autoimmune diseases, from rheumatoid arthritis to lupus, different conditions that are very, very difficult to manage because the body is essentially attacking itself. And when you talk about drugs with a negative side effect profile, you look up the drugs to treat rheumatoid, psoriasis, psoriatic arthritis, rheumatoid arthritis, lupus. Those are the most toxic drugs in our toolbox currently. The risk of death due to cancer, tuberculosis, a whole host of different conditions. Marijuana products, be they total plant-based products or certain derivatives, have proven effective time and time again in treating some of these autoimmune conditions. We're not necessarily sure why. We don't necessarily have all the information yet, but from a safety profile, we don't have anything else that compares. There just are no toxic side effects. As you mentioned, a tincture of thyme, a box of Twinkies, and a bottle of Izine, and the negative side effects associated with medical marijuana will dissipate. And there are no long-term consequences associated with it either, according to any of the most current up-to-date research. And yet, in randomized, double-blinded type studies done in Israel, done in Holland, done in places where we've had access to medical marijuana for longer periods of time, proven effective for conditions associated with inflammatory arthritis, inflammatory autoimmune diseases of the gut, like Crohn's disease or ulcerative colitis, and again, safe and effective. And compare that with any of the current drugs on the market, and they don't even loosely compare. So from a medical point of view, I can't wrap my head around why we don't have access to those kind of things. We put a lot off on the FDA, and I understand they're overwhelmed and understaffed, and they do a lot of good work. I'm not necessarily knocking them, but we continue to prove things in medicine that we thought were okay that weren't. So we're willing to accept a certain amount of risk when we practice medicine. That's the nature of it. But if you look at the benefits compared with the potential risks, there are very few things in medicine which can even closely compare.
Well, that was going to be one of my questions when I was listening to the debate on KT. I can't remember the gentleman's name, but he was making the point that I guess there's the trust your doctor. Is there a bill or...
I think they refer to it as a right to try. Or,
right to try.
Yeah.
And he was making the point like you had that when they started prescribing opioids. But that just didn't really hold water with me because it's not even remotely the same thing. You know, I mean...
No, and you mentioned the KET. One of his questions were as if it were a negative, what is the reversal agent for marijuana products? And I still submit that we don't need one. That we don't have one, and the reason we don't have one is because we don't need one. There are no instances of fatal overdose. And compare that to even something like Valium. I mean, the Rolling Stones wrote a song about it, Mama's Little Helper, years ago. You take more of those, you're going to get an overdose. I mean, we have flumenazole to reverse the effects. We have Narcan for the narcotics. And yet we still use those, and they do have clinical benefit. I'm not saying that they don't for the right patient and the right management. But to then say that we don't have proven safety and efficacy of the marijuana-based products is just not true.
So do you think part of the limitations on the research is because of it being classified as Schedule 1?
Absolutely. I mean, it's a catch-22 situation where you couldn't get the information that they requested because it was illegal to do the research. And
I want you to expand on that a little bit because that was one of the things when I heard that didn't really make a whole lot of sense to me. Was why can't you do more research on Schedule 1 narcotics? Like, what is it because they're illegal?
By definition, not just that they're illegal, but in defining them as that type of Schedule 1 illegal substance, you're basically saying there is no medical benefit. So you negate the potential possibility of any future study by saying there already is no benefit.
Does that make any sense?
Absolutely not. And I think, from common culture type comedy routines to common sense, the effects of marijuana compared to those of heroin, it's not a fair comparison. And if we do so, we're harming both. We're negating some of the potential effects, negative effects of more serious substances that are more harmful by comparing them with something that doesn't have the same level of potential negative outcome.
So House Bill 136. Where's it at right now?
It's in a pre-file stage, as I understand it. They're jumping on the gun. We've already got the language established. We've been through several committees last year. So, with the recommended adjustments that they brought with respect to, I think, self-grow last year, we're ready to file and filing that early.
And does it take into account that marijuana being a Schedule 1? What do you call it?
Yeah, we still have to deal with that classification as it stands right now until that would be changed on a federal level.
What is one of the, I guess, the kickback that I've heard maybe on these bills is the ability for a person to be able to grow, 6 plants? They could have 6 plants. What's the kickback on that? Why is that such a big deal? Because I think the one gentleman was talking that as long as they took it out, the state police would be okay with it. And again, it's one of those things that just didn't make sense to me, and I didn't understand.
Again, probably some of the stigma that goes along with it. I can't, from a medical standpoint, growing it at home seems like it would be even better if you know what your product is and you've got it right there. But I guess you do remove the potential for some of the clinical type standardization of the products, which if you get into an actual industry like they have in Colorado or Nevada or some of those places, they have access to testing so that you know what you're getting, what concentration, what strain, because these days it's not, 1960s backdoor dealings. This is scientifically developed stuff that we know what we're getting, and we can tailor effects for specific patients and for specific complaints.
And I think that's one thing that it seems like to me the numbers get a little skewed. Like when they talk about the states that started with medical and then went to recreational, and they'll say, well, they had 40,000 people under medical, and then when it went to recreational, it went down to 3,000. But that only makes sense to me because if I was coming to you for allergy medicine, but I could grow a bush in my backyard and get it there, I'm probably going to forego the copay and self-medicate at home.
And I think that does explain some of the reservations that some of those folks had. And although we did have a lot of support for self-grow, and I think there's a lot of logic behind it, I think they could also see a reason that could muddy the waters to a certain extent. And anything we could do for clarification at this point, and again, prove some safety and efficacy, baby steps. We'll get there eventually, and so it's a good place to start. And if it makes people feel more comfortable, I'm okay with making some concessions like that.
I think that's a fair concession. I mean, I think just to get us moved in the right direction as it comes to medical marijuana and actual treatment.
So let's talk about the CBD oil and the hemp thing that seems to be the rage right now. I don't know. And is that a valid alternative to medical marijuana in your opinion?
I think you could maybe even compare it with something like antibiotics, and we don't just have one penicillin. We have various forms of antibiotics to treat various types of infections based on location, based on type of bacteria and severity and things of that nature. And I think you could look, when we talk about medical marijuana and derivatives versus whole plant-based products, it's something that is still in an evolutionary sort of state. We're still learning bits about it, and how to necessarily define and tailor things specifically for different conditions, different patients. But that's really no different than anything else in medicine. And so if there are benefits to CBD-based versus CBD-THC combinations versus tinctures or extractions that are specifically THC versus THC and CBD ratios of different strengths. Whole plant medicine versus derivatives, they have different roles and can be specifically used to treat different conditions in different patients. So there are, back to your question, yes, there are benefits to CBD-based medications. Do they supplant or replace all the other whole plant or THC derived molecules? No. I think that's actually a very complex plant with multiple different potentials from lots of different medical points of view. And we need to explore all of them. I do believe there are a few things that are as safe and effective. Yeah.
One thing you mentioned this about for the autoimmune diseases, and there was at one time that I was prescribed one of the injections.
Gotcha. Yeah. And Humira or Enbrel or one of the big ones. Yeah.
And I'm looking through this thing and start digging into it, and the side effects, it was like rare kinds of cancer, tuberculosis, a number of things. And I'm sitting, I told my wife, I said, I'm not doing this. I would rather my spine fuse together and than all of these other things. So just the risk reward, that's the part that I really struggle with, is because I definitely don't know all the answers to this, and that's why we're, that's why we want you on here.
Right.
But it makes no sense when one part of the argument says, well, we can't even go down this avenue because we don't know the risk reward. But then on the other side, it's not only the things that have been out for 20 years that they're like, okay, we didn't know the long-term effects. We're talking about stuff the day they bring it to market. They're giving you a laundry list of these reactions that are horrible. And you see these on TV all the time. Every other commercial is a pharmaceutical commercial, and you'll see a commercial for a headache, and then the side effects for the headache, I'm sitting there thinking, well, I'm good with the headache. I'll stay right here where I'm at.
Uneven tire wear,
Yeah, it used to be, common fodder for comedians, but it's not a joke. The level of side effects, and again, I practice in a primary care environment, focusing specifically on musculoskeletal issues for practically the last 10 years. You mentioned some of the ads on TV right now. I think there are at least 3, if not 4 different drugs on the market that are of that type, the injectable $1,000 to $1,500, $3,000 a month type injections, that all come with that same list of side effects, which include the cancers and tuberculosis and death from a wide variety of causes. To manage psoriatic arthritis, now, I've been practicing for almost 20 years, and I think I've seen 3 cases of psoriatic arthritis, and my practice is focused on musculoskeletal management. And it's not because I'm missing it. It's not a misdiagnosis, but if it doesn't exist in any more frequency in a practice, a primary care-based practice like mine, is there a need for that type of medicine out there to that degree? 3 different companies, at least 3 different drugs that cost millions of dollars to develop. And how many people are they really helping? And yet you won't give us access to something that could help a whole lot more people for a whole lot, or a larger, wider variety of conditions, safer, cheaper. It really doesn't make much sense.
So we've been doing a series on the opioid crisis in Eastern Kentucky. And do you believe that medical marijuana could be a treatment for people, like Suboxone or something like that? Would medical marijuana be a way to help counteract the opioid epidemic?
Absolutely, and be it on the front end or the back end, be it to try to clean up the mess that was created by an opioid addiction, sort of the Suboxone strain, because again, I came through med school and residency in a time when methadone was there, and the Suboxone is just the new methadone, and we're just exchanging one for the other. And there's, in my opinion, nearly as many problems with the Suboxone and methadone-based treatments as there are with the other opioids. They are opioids. Let's not mistake what those chemicals are. So we're just trying to mitigate some of the negative aspects of that addiction or dependency to the opioids with other types of chemicals. So why wouldn't we want to use something that, again, would be safer and perhaps more effective in a pain management frame?
Right, and then not to mention and maybe you can correct me if I'm wrong here, do people get addicted to marijuana? People clearly get addicted to opioids. Clearly. There's a whole epidemic because of it. I don't know anybody. Look, when I was in college, we've all been there. I don't know anybody that was addicted to smoking weed.
No, I like to smoke some right now.
And there's no there. Again, you could almost look at it from a comedian's point of view, but there aren't rehab centers. I do believe one of the popular comedians had a bit about he went to seek treatment for a marijuana addiction and basically got laughed out of the Alcoholics Anonymous and Narcotics Anonymous because it does pale in comparison. And from a chemical point of view, from a neurophysiology point of view, the way the brain works with respect to these chemicals, there isn't the same addictive potential. It just does not work in the brain the same way opioids or cocaine or some of these more addictive substances work. And it does not come with the same risk of dependency.
Okay, so I'm going to dive into politics just a small bit here. You've got this House Bill 136 that brings forward medical marijuana and makes it accessible to Kentuckians. Is there one party that fights against it harder than the other party?
I don't think so, actually. And I was a little bit perhaps pleasantly surprised by some of the bipartisan support that we had in Frankfurt, at least. Nemaz is Republican, right?
Uh-huh.
He supported the bill. You would almost think that would be a Democratic kind of initiative and push, and yet there you have a Republican member of our state legislature that's the main driving force behind that. So
I think Rand Paul is also supports it, I believe.
Well, I believe that's going to be one of Trump's big things in the next election. I think he's going to push for the legalization of medical marijuana.
Trump train, baby, here we go.
I had heard that recently. I think this week, actually.
I'm kidding.
That he was making a push, and again, it's a wise thing to do, no matter which side of the fence you fall on. So,
one thing that just we were talking about the commercials, and we were talking about, and I know there's obviously a lot of. There's a reason that they're spending billions to put this stuff on TV, but now we're in a place, and I worry about even our younger generation that have just grown up, that in between cartoons you're seeing a commercial, take this, and we've got to a point to where, chemical medicine is roughly 100 years old. I mean, as far as it's really been out there. So now you've got chemical medicine that we know what the dangers are, whether it be opioids, whether it be these other things that we were talking about earlier. So to where now somebody like yourself that wants to take a more natural route, which was the way it was for thousands of years, now is looked at like a snake oil salesman.
Yeah, it's
so how did we get there?
Again, it's you don't want to be too much of a conspiracy theorist, but again, follow the money. I think ultimately the pharmaceutical industry and the amount of money that they invest in a product, they're doing research 20 years before the fact about potential avenues into a patient population where they can invest a certain amount of money and they get a certain amount of return. And I think once they go down a road so far, they're not willing to look back. But in my time in medicine, you can look at multiple drugs that were given FDA approval, went through the trials, and made it into common practice. Vioxx and Bextra were two drugs that were used routinely for arthritic type pain management, and did seemingly a lot of good, only for us to find out that they caused potentially life-threatening issues and were subsequently removed from the market. So we continue to go down a path, find out that we're wrong, and have to backtrack. So while we're afraid to pursue something that has been around a lot longer, and at least with all the evidence we have so far, shows no potential fatal risk or a negative outcome like that.
That's one of the things, even on the KAT segment, it was like, we just don't have enough research. And I was like, guys, we have marijuana around a lot longer than we've had Oxycontin.
Yeah.
To change gears just a small bit on you, I've read a few articles on the subject. It's been a little while now, but there is a theory out there that marijuana can cause schizophrenia in some people. What's your opinion on that?
I've seen different perspectives or thoughts on that, and I think correlations to that were probably in people where the condition was underlying anyway. Unfortunately, schizophrenia is one of those things that oftentimes pops up in the late 20s, around about the time most folks are going to college and beginning to experiment with alcohol, marijuana, different types of things. So I don't know that it would be a direct cause and effect, as more of perhaps a timing coincidence that folks that were susceptible to schizophrenic type issues, the marijuana type drugs perhaps lowers the threshold, brings those symptoms to the surface.
So it's an accessibility thing.
Yeah.
They got accessible to the drugs, and then that mindset came to fruition.
Right.
And I think we see that a lot with with it being addictive. And I'm not saying for some people it couldn't be addictive, but just with my experience, most people that I've known, it was they were going to find whatever drug that they were going to find. Like you had your people that they were just going to smoke marijuana, and that was it. But the people that were going to do cocaine or that were going to do whatever else was out there, that was just the first thing they could get their hands on. So it was just a proximity thing. It wasn't that they
sort of the gateway myth,
and then it was like, oh my gosh.
Yeah, and again, in one of the committee meetings that we were up there, one of the representatives, one of the legislators, put it more delicately than I could, but she said perhaps not a gateway drug. This is perhaps an off-ramp drug. It actually, to consider it as a gateway to other things, again, these folks were probably going to go down that path regardless of marijuana, regardless of alcohol, regardless of nicotine or tobacco and those kinds of things. I think there is a certain genetic predisposition to addictive potential, and those folks maybe need different kind of support regardless of what's available in their community. But the potential for it to be an avenue of treatment for, again, a wide variety of conditions, some of which could be mental health issues, presents it as less of a gateway drug and more of an off-ramp drug, a potential to find something safe and effective that doesn't involve a lot of addictive potential or negative side effect profiles.
And one reason that really wanted to get you on here and get your opinion is because listening to you in the other debate, I got the impression that your end goal, like what would satisfy you, would be for your patients, for you to be able to get to a point with your patients to where they're not your patients anymore, right? To where they could be fixed. I don't, with a lot of the other medicines, and especially the chemical medicines, and going from this one to this one, and then by the time you're on 4 or 5, then you're taking more medicines to treat the symptoms of what you're already taking. So as far as the studies and those things go, it seems to me like, I don't know if a better way to put this is almost that the foxes are guarding the hen houses as far as some of the studies, because if you went this route with medical marijuana and it was as effective as a lot of people think that it would be, it's going to close a lot of doors. So how do you get around that?
From a pharmaceutical point of view, or the machine that is the pharmaceutical industry, I don't think they do. And I think that's where you see a lot of the resistance coming from lobbyists for the pharmaceutical industry on a state level, on a national level. They are throwing money at this and lots of money at it. Different states that have gone legal have different methods of marketing, whether it be a sort of a horizontal type marketing method or a vertical marketing method. And that gets into sort of the industry of marijuana, whether you have mom and pop type facilities that can grow it and supply it to individual clinics or dispensaries or patients, versus bigger organizations that have more perhaps scientific equipment for testing and certification and things of that nature. So that's currently being done at the state level, and we don't have any federal guidelines, again, to help point us. I'm not sure which of those I favor. I think there are benefits to both. Perhaps inevitably the truth somewhere in the middle, a combination of those type of marketing schemes where you didn't exclude individual growers, mom and pops. If you could say, like Mr. Conway said, grow an acre as an individual, sell it to a medical marijuana facility, let them process it, certify it, then it goes up the marketing chain to the individual dispensaries. I think that would be the best way to go. Now, that's going to make money for somebody, be it the mom and pops on the individual level or be it the bigger dispensaries. But I don't necessarily know how the pharmaceutical companies feel like they get their fingers in that pie and get their fair cut, because in all honesty, they don't. But that's where I step back to say, why do we have 4 drugs for psoriatic arthritis on the market when I've only seen 3 patients in 20 years with psoriatic arthritis? They saw a window at some point in time during their product development schemes, and they've invested a lot of money in it. So they're not going to shift gears now and try to get a finger in this pie when they've got so many fingers in other pies. It's It's a difficult situation for them to be in. I'm not envious, and I don't know how we get around it other than continue to fight the good fight and prove that it's safe and effective. The main problem is their products are not safe, and they're not very effective. And that's the problem, trying to compare it with something like what they're doing.
And what other, whatever other business was something that serious, like all these commercials will say, well, ask your doctor about this. Well, when I come to see you, you're the expert. I'm coming in there because you need to help me with my health needs. It's a little concerning to me that I can come into you and request a specific, what do I know about the medication beside the commercial that I saw?
Right. And they, be it the pharmaceutical industry or the insurance industry, they've done a good job of pitting doctors against patients. And ultimately, the more critical our time got, be it because of electronic medical records, doctor shortages in patient areas that need access to medical care, we're in a position where we are still in a business. We are in a business where we do try to make people happy. If we tell people everything that they need to be told, they might not come back. They really might not, and because they can go across the street and find somebody who's more strapped for time that will just tell them what they want to do, write them what they want, and get them on out the door. I spent several years teaching at a med school, teaching primarily osteopathic medicine, but I also taught in the family practice department. And since I entered med school in the late 90s, through my time teaching in the mid-2000s to the mid-2000 teens, the push to teach evidence-based medicine is paramount. That's the biggest thing, the most important thing. It's got to be evidence-based medicine. But the more I looked at this evidence-based medicine, where does that evidence come from? That evidence comes generally from the folks that are funding the studies for whatever drug, whatever medical device, whatever procedure they're looking to get approved. And John Oliver did a wonderful piece about the approval process. That's a whole separate, that'd be one that you want to come back and talk a whole other hour about. But the approval process for medical devices and drugs and things of that nature is far from ideal, say the least. But when you take all those things into account, there's the safety and efficacy is not there. And we might sort of believe that it is. And I think that that's a significant problem in how we choose to pursue different avenues of treatment.
I have more kind of a specific question, and this is just more from my everyday life. And the young lady that cuts my hair has an autistic son.
Sure.
And he's, moving into his teenage years. He's can't get settled down. And so she has been talking to me about CBD oil and some other things and wanting to try. She's trying to find something other than this big bag of pills,
right,
that they want to give him.
Mm-hmm.
And do you know of any cannabis-based treatment for autism? And that's a big thing these days too. Autism is more and more prevalent. Is that something where that could be applied?
I do believe there are some at least preliminary studies, perhaps not done in the U.S. I think I saw one in Israel that may have pointed to some beneficial effects there, but I think those studies are still preliminary at best. The CBD-based products that we do have access to now, given the effectiveness in other conditions like epilepsy, other neurodegenerative conditions, post-traumatic stress disorders, things of that nature, I would say it's worth a shot. If I had an autistic child or family member, I wouldn't hesitate to try what was available or legal, and I think that would be at least one method of trying.
Because that's always been one of my biggest things is the fact that it is illegal. My dad had cancer. He was very sick. A lot of, the chemo, the whole thing. And if a joint would have made him feel better, and he wouldn't do it because it was
the
illegal.
stigma associated with it. Yeah.
But he said it's illegal. I can't do that. Mm-hmm. And I know in my heart of hearts that it would have helped him. Mm-hmm. It would have made him feel better. And that's one of my biggest things with the medical marijuana argument is how could you, if you've got a child or somebody that's hurting and something this simple that you can make them feel like a criminal because they want to, because I mean, I think it clearly helps. I think the evidence clearly shows that it helps.
It's criminal of the medical community to put that upon patients. It really shouldn't be a topic of discussion. I can't think of anything else in the medical community. Aspirin is not as safe. Tylenol is not as safe. You get into the heavier gun pain management. Ibuprofen destroys kidneys, can be linked to heart disease. The simplest over-the-counter medications. Benadryl can cause some people to go completely off channel, have hallucinations, the whole works. Medicines that have been around that we give to kids, baby aspirin and Benadryl, that cause devastating negative side effects. Nothing comes without risk. So I don't want to downplay the issue. It's still medical management. It is still a drug. It is still a foreign substance. But compare it to anything else in the entire pharmacopoeia. Nothing else compares. It's just not fair. And to deprive a patient that could benefit when they still probably were willing to pump morphine in them if they were in pain, where they were still giving them chemotherapeutic drugs that we don't necessarily know why they work or how they work. I just watched a piece the other day that discussed, we don't necessarily know why anesthesia works. We just know that it does. We don't necessarily know the long-term potential negative outcomes, what it does to the brain chemistry or brain physiology, and yet we still use it. And if I got to have surgery, give me a little anesthesia. I'm okay with that. Okay, we have to be willing to accept a certain amount of risk, but to not be willing to accept the risks associated with this type of medical management, given the potential benefits, it doesn't make sense, and it ultimately probably goes back to the money.
So, we do have states where medical marijuana is available to the public, and I'm sure you have information from their clinical studies or whatever.
Uh-huh.
What is it more effective from a medical standpoint? Is it more effective in pill form? To smoke it? Like, is there a difference?
I do think, and I think we're just getting to the point where we're starting to see some of that play out. I don't think we've got all that information yet. I think it would be safe to say that edible forms are better for certain conditions,
Sure.
The inhaled for other conditions versus, edible tinctures. Different preparations would definitely benefit different conditions. I don't think we've got all that information yet. And some of it may honestly be patient dependent. Different patients are going to have different, we got to take into account the individual nature of the patient as well. And when you begin to do that with a complex product like that, it becomes difficult. It's one of the reasons the pharmaceutical industry, given the way it's set up, can't find a way to get in. They don't necessarily know, because you can't just take one aspect of this and make it work for a particular condition and get the randomized double-blind studies, because it's a combination of effects, be it a combination of different aspects of the plant, a combination of different aspects in the individual, given the nature of the treatment or the condition you're trying to treat. So it becomes a very complex process. And, we don't want to just be throwing a shotgun approach at medicine either. I'm fine with a very specific, directed treatment approach. And I think I would stick to that if it were a potentially more dangerous medication. But I think given the nature of the side effect profile, the potential benefit that you can have with a wide variety of conditions that honestly can be quite devastating, be they cancer diagnoses, inflammatory conditions like Crohn's disease or rheumatoid arthritis, emotional health. We've not even touched or scratched the surface of post-traumatic stress disorder. The benefits for our veteran community, the folks that we've sent to war for the last 10 years, the benefits given, again, the nature of the current medical management tools that we have. Let's shotgun them. Why not? Let's go ahead and throw everything we can at them. If it helps, it helps. As long as it doesn't hurt, who cares?
Amen to that.
Yeah, I saw. I've seen some things on Parkinson's recently that looks like that it's been effective with that.
Mm-hmm.
And I lost my grandfather a few years back, and at the point that he was at before he passed,
My
if it didn't
grandfather
work,
had Parkinson's as well.
It didn't
Yeah.
work, but
Oh.
you sit there and you just watch them and you think, why can't we try this? But we can try anything else.
Mm-hmm.
And I know the entire show we've talked about the medicine aspect, but something else that just kind of blew my mind is going through. I went to a number of different arthritis doctors, different pain doctors over the years with some different things a while back, and I only had one physician, and everywhere that I went, only one that had a conversation with me and said, before we look at anything else, let's look at what you're eating. Let's look at the processed food.
Mm-hmm.
Let's look at your vitamins, and let's start there and see how your body reacts, and then we'll work from there. Only one.
Only one.
But you can go anywhere. I can go almost anywhere and talk about one of the chemical medicines we see on TV, and it's just like M&Ms. You get whatever you want. Yeah. So I don't know how we fix that. I don't know. Is that starting in medical school?
Again, I would say it even goes back to medical school, and even you should be doing more groundwork pre-med. Even you might even say go back to undergrad. But dietary things are not taught in medical school. Very limited education with respect to diet, potential outcomes, different management. Other than don't eat fatty foods or something like that, we really don't discuss it. There's probably an hour lecture built into a 4-year medical school regimen. We do not do a lot of that type of education. So yes, it starts in medical school. And again, if you look back to what I was saying almost about medical marijuana, where is the pharmaceutical industry going to get their hooks in on the dietary stuff? I mean, now we're talking all across the board. That pie is really going to get cut into a lot of slices. And so, as I mentioned before, the primary thrust, and this had to be driven by dollars and cents. We say it's for all the right reasons, but ultimately the studies don't support that. But everything's back to evidence-based medicine. And so if we have to have a study that supports it, who funds that study? Who pays the people that are crunching the numbers for 2 and 5 years to get the data? If there's not a paycheck on the other end, we don't do studies just to prove that it's right. And all that dietary stuff, all the natural stuff, back to almost a medical marijuana type discussion, there's not enough money in it for somebody to do a study, to provide the evidence, to then get into the medical textbooks and make it into one of my lectures in medical school. It's just not going to happen. There's got to be some money behind it somewhere, and it ain't there.
And we've talked about this even on previous episodes. But everything that you see in a lot of these that seem like great causes, but everything is about let's find the cure, let's find the cure, let's find the cure. But it doesn't look like anything that any of these resources are going towards the root cause of where is this coming from. And it looks to me like that we keep building on something so we can keep treating the symptoms.
It is a treatment.
So the pharmaceutical companies can continue to make more products to treat symptoms.
Band-Aids.
Yeah, absolutely. I mean, our entire, it's one of the things that philosophically should differentiate an MD from a DO, but we're products of our environments. We being DOs, we're products of our environment as well. The evidence, the studies, the things that are in our textbooks are the same that are in the MD community. And so if you look at historically our foundation post-Civil War to where we are now, there's not as much of a philosophical difference between most DOs and most MDs. And even though philosophically a DO should be looking at eliminating a cure or eliminating a cause in order to effectively cure that patient, the tools we have in our toolbox are the same that are in the MD community, and therefore they are geared at just band-aiding it, treating that symptom, keeping them coming back. I hadn't practiced medicine for very long before I was back in the paper chart days, handwriting prescriptions. And one of my first complaints was multiple prescriptions, just month in and month out, having to write the same prescriptions. 5, 7, no, that's nothing. Multiple patients, 20 prescriptions each month. 3 prescriptions to treat side effect of one medication. It's not 1 for 1. It's 3 for 1. Right. You get 1 medication, you got 3 drugs to treat side effects from it. It's awful. And as a doctor, you don't know where to intervene because they did cover up symptoms with whatever medication they were getting that patient on before they got to you. And therefore, to remove that element is difficult. You're going to make a patient uncomfortable. You're going to make them unhappy, if you take things away. And so it's a very difficult world to try to practice in, and very difficult for patients because, again, all we're fed are your life will be better if you take this medication. You're going to be younger, smarter, better looking, make more money if you take this medication. It just doesn't work that way. Again, I'm the one, as a family doc that has to pick up all the side effects. You go see a specialist and you take their medication, you get a side effect, go see your family doc for that nausea, vomiting, diarrhea, headache. I'm the one that has to pick up all the pieces. And then what can you do? You give them something to try to cover up that symptom. Or you tell them that, no, you don't take that. Well, what do I do for the condition I was taking that for to begin with? When in reality, it goes back to a low vitamin D level. They don't eat right and they don't get out in the sun, So there are so many things that could be done with fundamental changes. But where I started in med school, the things that we had to learn compared to when I left the teaching environment, we put so much stuff in. Really, med school should probably last longer. Add a couple of years. We've added a lot of material. We've not added an extra year or two of med school. Yeah. That might help.
So, one of the things that frustrates me with this whole debate is you see these people, whether it's cancer or whatever it is, people are in their, 90s, late 80s, and coming to the end of their life. And we all know death is a part of the journey. It's going to come. And so they call hospice in, and what they do. They pump you full of these pain medications, and now you're just laying on the couch for 4 days till you die. Mm-hmm. But I feel like they're stealing time from you because those are times where maybe you could use miracle marijuana to enjoy those last 4 or 5 days. Yeah.
Absolutely. Without the sedating effects, without the potential respiratory depression that comes from morphine, it's worse than a shame. It's criminal what we do to patients in that situation. Some of the things that we feel quite comfortable pushing are no different than street drugs. And heroin and morphine are very close cousins. And the potential fatal negative outcomes are the same with both. And yet you don't have that with medical marijuana, and somehow they're labeled the same. Morphine is not a Schedule I drug. It supposedly has medical benefits, which I don't think we would argue. I think if we were in a position where we had to take it, that we might want access to it. But to put heroin and marijuana then in the same, it just doesn't fit. Right.
So I'm reading a book. I think the author's name is Beth Stacy, and she wrote a book called Dope Sick. It's about these people coming off opioids. And it's about the opioid epidemic, mainly in Virginia, Lee County, Virginia, or in Roanoke.
Did that transition into a History Channel show or a Vice show? They had Dope Sick Nation. I wonder if it's the same group. I wonder if that's...
I don't know. Possibly.
Yeah.
But the idea behind Dope Sick is, people trying to transition off opioids, and they would get dope sick. And they would get the nausea,
right,
the diarrhea, the just anxiety. And I almost feel like, man, I know this may be a Band-Aid too, but wow, how many people would potentially get off these opioids if we would let go of this, what you call criminal legislation that keeps it banned?
And like I say, be it the front end or the back end, be it, you don't ever progress to the point where you're using opioids because you have access to better anti-inflammatory medication on the front end. I have had patients that couldn't take NSAIDs because of kidney dysfunction, because of heart disease, because of blood pressure problems, because of allergy. And once you eliminate the anti-inflammatory class of medications that we currently have, you really don't have anything other than to tell them to go do things that they don't have access to: acupuncture, cupping, Pilates, yoga, things that folks in our community really aren't going to have the access or the time or the energy or the extra money for. And yet we won't allow them access to a tool before we get to things like advanced pain management tools such as opioids or epidural injections, facet blocks, surgery. We're not letting them use a tool that could potentially keep them from getting there. Now, what could we do on the back end where we're trying to transition people off to prevent the negative side effects associated with the detoxing procedure? A whole host of things, from the emotional aspects associated with the mental aspects of the addition, the mood disturbance, versus the physical aspects of that detoxing process, the nausea, the gut disturbance. Again, we've got a tool that's staring us right in the face. That for a physician in Kentucky, I'm envious of the folks in surrounding communities that do have access to the potential to use it legally, medically.
So is there any kind of push to take some of these things that we could exhaust, trying, whether it be acupuncture, massage, chiropractic? I know most of those things, as far as insurance is concerned, you're not going to hardly get anything covered. So would we not be better served to throw some of the insurance money at those type of things, with some more of the, some of the natural things, before we jump into the medicine? And is there anything going on to go in that direction?
Well, yes, and I think, unfortunately, it varies. Different insurance companies have different allowances for conservative measures for pain management. They're going to have limits, and unfortunately, they have a tendency to change those things routinely. So as soon as you get used to one routine, they're going to change it a little bit. Ultimately, I think that's back to the bottom line for the insurance companies. They're in business to make a profit as well, and with a lot of conditions, they're unfortunately, we do talk about the Band-Aid process, and we would like to eliminate a cause and cure things when we can, but there's a lot of things that we can't cure. Once a back's so bad, you can't necessarily erase the effects of a 20-year coal mining history. You can't change the effects of construction history for 12 years, or a fall from a ladder, or a major trauma, things of that nature. So, there is a need, and will always be a need, for ongoing treatment and management. But when you look at the routine that we have now, we jump straight from routine things like that. If physical therapy doesn't fix it after 6 visits, then you can get 3 epidurals a year and that's it. We don't have a lot of in between. They don't give you a lot of access to acupuncture, to nutritional advice, or natural methods, homeopathic methods, other things that may not necessarily be proven, but again, if it works for you. One of my mentors, when I got into teaching in med school, he used a term when we talk about evidence-based medicine: the N, or the sample size. The larger the N, or the larger the sample size, generally reflects. But from a doctor-patient point of view, the only thing that matters is an N of 1. Sample size doesn't matter when you're the patient and when you're the doctor. It's just that one patient and that one doctor. Everybody else doesn't really matter. The most important thing is that individual. And if we had more ability to specifically tailor things for the individual, then we could find methods that were safe and effective, non-toxic, non-addictive, even if they don't necessarily have the evidence perhaps to support it. I'm okay with that if it works and it's safe.
Because I know you've got a lot of people, especially with dealing with the opioid epidemic, that now are seeing the dangers, that would rather go another route. And they say, well, I will try massage, I will try physical therapy. But the difference is, say you're sitting there and you've got 3 or 4 kids at home, mm-hmm. right? You're worried about paying rent that month, and you can say, okay, I got 2 options. I can go to physical therapy 3 times a week and pay $45 a pop.
Yep.
Plus do this, plus pay $50 for a massage, or I can pay my $4 copay and go get a bottle of pills.
Yeah.
And I think some people do things just because that's what they can afford to do.
Convenience and economics always going to be a factor. Absolutely. And even if they don't have coverage, a one-time prescription once a month is going to be cheaper, like you say, than 3 visits to the physical therapist and a massage session or 2.
And sometimes I know how it is in politics. You just kind of feel like you're grinding your nose off your face trying to get something done. And the wheels turn slowly. Have you seen people that were against this originally? Have you seen them come across the aisle and reach out and accept what you're all trying to do?
I think I was pleasantly surprised with the outcomes in the legislative session last year. I think there was support from some folks that maybe were on the fence, and we were happy to see them come over to our side. Unfortunately, not sarcastically, but honestly, the ones that weren't supporting, you could sort of see a reason as to why they weren't supporting. Again, if you follow the money, you see who their supporters are. You don't have to work hard to do the math to figure out why they were obviously not supporting. And I hate to be cynical, but that's the reality of it. And when you're supported by the pharmaceutical industry or the drug rehab industry, you may have a reason to not support something that might directly affect your bottom line. I can understand that. Doesn't make it right, but I can understand it.
So is there a way in your mind to fix that? I mean, as far as it being a conflict of interest, to receive money as a legislator from a pharmaceutical company or something that would benefit the bills that you're passing? Because to me, that seems like a no-brainer. But at the same time, I'll talk out of both sides of my mouth because I don't know the right answer of how you fix it.
I understand that, and I'm right there with you actually on that. I recognize that there's an issue, other than to just sort of blanketly say let's remove money from politics. But what does that mean? How do you really remove the money from politics? How do you get the lobbyists out? And if we remove that, how do you get information to the people? We live in a complex society. I understand there needs to be a little bit of give and take, and I don't know where the right balance is. But we sure do seem, to be on the wrong side of it with respect to this one, and it doesn't seem like it should be hard to fix. It's not life-threatening. It's safe, and it's effective, and it's beneficial. So, on this one, you ought to be able to figure out who's motivated by what and remove some of that potential conflict. But again, I'm like you. I don't know the specifics and the right way to handle that on a state level, on a federal level. That's difficult.
So my last question, and this is just more from personal curiosity, when I was in college and I was doing my research, I found that there were many different potencies of marijuana. And, one of the things that kind of came to mind when we were talking about people being able to grow at home, there are different potencies.
Mm-hmm.
You got Mary Jane Baker in her kitchen, cooking up some brownies, and next thing you know, you're talking to the dolphins.
Right.
Is it important in your mind to have that stopgap where people, really bring the science into it so that you can control when you've got these different potencies to be able to control that?
Absolutely, and I think that would benefit everybody across the board, from the folks that are concerned about what we're actually putting into our body for whatever reason they have their concerns or reservations. If we can quantify and qualify strengths, strains, percentages, regardless of the delivery method, be it whole flower, be it one of the extracts or edibles. I think that benefits not only folks that would have reservations about using it, but also allows doctors, medical providers to more specifically tailor, a particular complaint, patient, and treatment regimen. It makes it much more specific. And again, I think the gentleman that just lost for agricultural commissioner, Conway, had a great idea and it would actually kind of be a combination of the horizontal marketing, the mom and pop versus the big corporations. You know, I recognize mom and pop's not going to have the same quality control as somebody with more resources. So how could you combine that? You allow mom and pop access to specific seed strains at a reasonable price, you know, and they grow their 1 acre. They make $40,000. They send it up the line, and it gets quantified and qualitatively.
You could have an economic boom in Kentucky. I mean, there are a lot of farmers here. I mean, people who farm. It could be an economic boom.
Everything that we lost in tobacco, all those small little greenhouse domes you saw in February getting ready for the spring plant. I mean, we could have that back on the side of any hill, be it Martin County, be it Clay County, be it Western Kentucky. And if you have the access in the area, go big. But if you're a small mom and pop, if you could make $40,000 extra bucks for growing a little something in your backyard, what does that do to our community at large? I mean, that's a tremendous boom.
I grew up in central Kentucky where there were, you know, until I was in high school, there were tobacco fields on both sides of the roads anywhere you went. I mean, that's what you did in the summer, right? You set tobacco or cut it, or that, you know, that's how you spent your summer. And then here specifically in this area, you know, with the coal industry. So, you know, I don't know all the answers on this, but it seems to be effective in helping people. So if that's the case, and if we can help people, and we can eliminate some of these other issues that we're having from the chemical medicines, then why would we not get on board with that and bring money into the community?
Yeah, the risk benefits alone make it worthwhile. To then think about all the downstream potential benefits from economic run on down the line, it seems to be a no-brainer, which, again, why do we have to even have this conversation? Right. So keep your fingers crossed for House Bill 136. That's
so
it.
We're a few minutes over an hour here, and so I think the last question I would like to ask, because I think was kind of sum this thing up, like going forward, you know, House Bill 136, obviously, but what would you like to see happen in the state of Kentucky with medical marijuana going forward? Let's say 10 years from now, where would you like to see us?
I would love to see us at the forefront of the medical marijuana industry. I mean, right or wrong, again, if we go back to the late 90s, we were famous for the marijuana industry. We were famous for the moonshine industry in years past. If we can remove a little bit of the negative stigma associated with it, why couldn't we be back to the forefront? I mean, we're at the forefront of the bourbon industry. I mean, there's not much medical benefit to that. Why can't we be at the forefront of another industry that seems to be rooted in us historically, and down to the do-it-yourself kind of initiative that mountain people and even the folks out in Western Kentucky are known for. I mean, we are self-sufficient people that like to take care of one another, and this one seems like one that we should be identified with. And why we are on the old proverbial hind tit is beyond me. Why aren't we up front with this? That's where I'd like us to be. Get back to the forefront and find a way to do it across the board where little guys can benefit, not just big corporations. That's where I'd like to see us.
Well, that's awesome, man. I said I've really enjoyed this.
Good.
But I also can't end the podcast without commenting on that fantastic bow tie. I will make JD take a picture and post it on Facebook. I've admired it the whole time I've been sitting here, and I cannot end the podcast without telling you how awesome that is.
And that's a real tie too. That's not a pre-tie.
Oh no, that's the real baby. That's right.
You tie that yourself though?
I did. No, she had to look it up for me though.
No, Jared, thank you, Dr. Mann. We appreciate you coming down. It's
great fun
and doing this with us. I've really enjoyed the talk, and I mean, I think from all of us, I said, just a lot of good questions, and we appreciate your candor.
We'll do it again.
Yeah, I love it. So, guys, thank you for listening. From myself, from JD, from Brad, thank you for listening to the Just Add Bourbon podcast.